the Gerontological Society of America, Advancing Innovation in Aging. GSA on Aging. I'm Howard Degenholtz, social media editor of The Gerontologist, a publication of the Gerontological Society of America. I spoke with Emily Franzosa. She works at the Bronx VA and has just earned her doctorate from the Department of Community Health and Social Sciences at the City University of New York. Emily's recent paper, Who's Caring for Us? Understanding and Addressing the Effects of Emotional Labor on Home Health Aides Well-Being, appeared in The Gerontologist. We talked about her research and what she's working on now at the VA. Afterwards, I talked to my mother. Tell me a little bit about yourself. You got your degree at CUNY at City University of New York?
Before that, I worked for a long time for the benefit fund that provides health and pension benefits for unionized healthcare workers in New York, 1199. And so that's really how I came to look at the work that home care workers do, because we represent many thousands of home care workers working throughout the city.
So, Emily, tell me about your recent paper in The Gerontologist.
Sure. So in this paper, we were looking at the emotional labor that that home health aides bring to the job when they're working with their clients. And I got interested in this because we know that technically home health aides, we think of them as providing physical care. So they help older people bathe and eat. They do some household tasks, and that's really what's on their care plans. That's formally what the job description is. But if you talk to home care workers or the people that they care for, you know that there's actually much more that they do. They provide a lot of companionship. They provide a lot of emotional support, but they don't really get training or preparation in doing that. They're sort of doing it on the fly. So I really wanted to look at what this emotional care that workers are providing brings to home care and how we can better support it so that clients are getting that real full range of physical and emotional care that they need, and that's really important to quality care.
That's very interesting. So was there a training component to this to the study?
For this study, there was not a training component. We did focus groups with workers where we pretty much asked them questions about how they perceive quality care, what quality home care means to them, what they need to provide it, and the barriers that they experience in providing it. And a lot of the things that came up, the really strong themes, were around this emotion work that's really in a lot of ways what you might call an invisible job requirement. It's something that you have to do, but you don't really get training or support or compensation to do it. And the idea was that with that we might either develop trainings or develop other supports that agencies could put in place to help workers do that work better.
The findings are similar to work I've seen in the nursing home setting. Have you thought about the parallels between home care workers and aides in a nursing home setting?
Sure, absolutely. So in institutional settings like nursing homes, there is much more work on these relationships between residents and the people that care for them. Home care is a really unique space because it's not institutionalized. So it's somebody who's providing pretty intimate services, but really alone. There's very little supervision. It's generally just aides and clients together, alone in the client's house. Sometimes there's family there, sometimes there's not. So it's really up to aides and clients to negotiate that job and those relationships in a way that you don't really see in institutional settings, where if you're having a problem, you can go to a supervisor and say, I'm having a challenging day with Mrs. Smith. What can I do? access maybe training that's available or other supports that are available. That's just not really the way that it works within the home health industry.
I was very optimistic about the nursing home setting. I was.
It is. Well, let's say there is maybe the option of doing that in a way that there's not in home care.
Well, one of the findings that I'm familiar with is that workers who have positive relationships and connections with the people that they care for are much more satisfied with their work and more likely to stay on that job for a long time. Do you think that's also operating in the home care space?
Yeah, absolutely. So a lot of workers told us, in this project and across other projects, it's a pretty consistent finding that the reason that workers stay in these jobs is because they love their clients and they find the work very emotionally rewarding. So it's emotionally challenging, but it's also very emotionally rewarding. And what we know from other research is that emotionally demanding jobs aren't necessarily bad. They can be very rewarding. They can help you problem solve. They can help you feel like you're getting challenging work done, and you can really feel like there's value in them. But in order to get that benefit, the work environment and the structure of your work really needs to support it. And we know that turnover in the home care industry is incredibly high. People are leaving those jobs all the time, but what workers consistently say is that even though the wages are very low, the benefits aren't great, they often feel bad leaving their clients.
In the work that you did for this study or in your other work, did you include workers who are also family members of clients?
We did not. So the workers in our study are unionized home health aides in New York City who were caring for non-family clients and all Medicaid clients. So it's a pretty low-income group of both clients and workers. We didn't include family caregivers in the study in particular because, of course, with existing relationships, there are a lot of complicating factors there, which is also something that's really important to look at and that I'm looking at in related work now. But the challenges of family caregiving are different and a little more, I don't want to say more complex, but complex in different ways.
I'm thinking about family caregivers or relatives of the care receiver who is also a paid worker, either through an agency or through a cash and counseling or consumer-directed model. And I agree that layers on a whole another set of issues and concerns. But I'm wondering if the underlying psychological dynamic of relationships is at play and similar in those types of worker to client dyads.
Right. I think that is a really interesting question and well worth exploring. My guess would be that there are similar issues, particularly around things like negotiating boundaries, negotiating care. One of the big differences in the consumer-directed model is that you're employed directly by your client. So in that case, if it's a family caregiver who's employed by their client, there really is nobody to go to. An agency-based aide can call their supervisor, although aides in our studies said that they often had a lot of trouble contacting or connecting with their supervisors. But at least there is some outside authority or supervision, even if it's limited. In the consumer-directed model, you don't really even have that. So I think it would be interesting to look at those questions of how that emotional complexity works into, you really just working for this one person.
Right. I can imagine that they would be committed to the care recipient, but also in very different ways, they're also kind of bound to that worker-client relationship, and they're doing it in no small part because it's their job. It's either could be their primary income or supplementary income. So there's multiple levels of dependency and relationships and supervisor relationships layered on. So
right, absolutely.
So the positive aspects of that caregiving and the stress related to that caregiving and I think what you keep coming back to is very interesting. It's the lack of another supervisor, mentor, expert, manager who can either provide support or emotional support or technical advice is lacking in that consumer-directed model.
Right. And one of the things that we also found in our study is that it's not necessarily just supervisor support. Aides were really hungry for connection with each other because, again, not only are they not really seeing supervisors in the field, but they're not seeing other aides. So you don't really have a chance to sit down and say, I had this problem with my client today and I didn't know how to manage it, and have, either just vent about it or have somebody give you advice. And that was something that they really wanted very strongly, whether that was in the form of something like a support group or a social network or even just coming together in classes or trainings, or even in the focus groups. A lot of aides told us that the focus groups had been really beneficial to just get together with other aides and talk about what was happening.
Yeah, that's very interesting. That's a very interesting finding. Right? You're trying to be a neutral observer and collect information, and it turns out that you're having a therapeutic effect, or actually what's supposed to be neutral data collection is actually becoming an intervention inadvertently.
Right.
Yeah.
Right. And as I would push back and say that there's not ever really neutral data collection, but part of the work that we were doing here is that we really wanted to involve aides in this process and make sure that their voices are heard, because these are often folks who, when we talk about the healthcare team or the support team, aides aren't really a part of that team, and we're not including their expertise. So we were actually really happy to see that just the focus groups themselves were an opportunity for aides that they found beneficial, because ultimately that's what we want to do. We want to help these folks, improve the quality of their working lives.
How generalizable do you think these findings are, given the setting where you conducted the research, the union in New York City, the pay structure, programmatic structure in New York is relatively unique. So I'm wondering if you think that your findings will generalize to other settings.
So that is a great question, and definitely one that we thought about. I actually think in looking across the literature, gerontological and sociological and the health services literature, our findings are remarkably similar to what we hear from aides about their experience in the home, particularly things about the efforts that they take to build relationships with their clients, the stresses that they have on the job, both emotional and economic. So I think in that sense it is very generalizable. I think what's interesting about this population is, as you pointed out, the unionized New York City home care workforce is one of the most privileged in the country. They earn slightly higher wages. They're eligible for health benefits and for modest pensions. They have access to training benefits if they qualify. But the fact that we're still hearing these same issues, I think, really says that we need to raise the floor for all of these workers.
So, Emily, tell me, what are you working on now? Congratulations on starting your new position at the Bronx VA. What are you going to be?
Thank you very much.
What are you going to be working on as you get settled in?
My hope is that I'll be able to use these findings to support home care services for our veterans. And we're still thinking about what exactly that's going to look like. But we definitely want, or I definitely want to look at how to develop this research that really connects and quantifies the emotional care that aides provide, the stuff that now we call off-plan care or extra care, but that we know is really central to client care. We know that in this environment where we're really looking at things like quality and value, if you can't measure something, it doesn't really exist. So we want to really understand how the work that aides are putting in, especially the emotional work, relates to patient outcomes. And are there other patient outcomes we should be looking at besides things like hospitalization? Can we look at whole health issues like connection to community and mental health and, satisfaction with your life, or those things that are important that we can tie to aid care?
Will you also be focusing on strengthening the workforce?
Yes, I mean that's a really critical issue. As I think I mentioned before, turnover in this workforce is incredibly high, up to 80%, and so we're losing, literally, thousands of workers. Many more than thousands. And over the next, 10 years or so, we're going to need to fill literally millions of these jobs. So we've got to figure out ways to keep people in these jobs and to attract more workers. And that means they need to pay better. They need to provide supportive benefits. They need to have supportive supervision. They just need to be livable.
I've long thought that a challenge for people in these jobs is all of the things that you said, the attention to the emotional aspects of the work, and ways to continue to support and reward people who do this work because of the relationships that they're building with their clients, and having ways to think about doing that work and continuing to do that work that does not include being promoted out of your skill set to supervision.
Exactly.
Or some other administrative job where, yes, you can be paid a little bit more, but now you're no longer doing the work that you found to be so rich and have that interpersonal connection.
Right. You're exactly right. I think, these jobs don't have to be bad jobs. And some people take these jobs because it's what's available, and some people take them because they really feel like it's a calling. And our focus in workforce development for so long has been about training and upgrading. You start as a home health aide, but you could be a nurse, you could be a supervisor, you could be a manager. But as you point out, some people don't want to do that. Some people really do want to do this direct patient care. So that work really needs to be rewarded and supported. And our aides had, in our focus groups, had a lot of ideas about how that could work. They suggested trainings that could be focused on workers and how to manage the emotional side of care. They talked about things like peer support groups. They talked about things like having supervisors help to negotiate boundaries with clients and patients. There are a lot of ways that these jobs can become rewarding jobs that you can stay in for your career.
It occurs to me that we often think about training as like an antibiotic. You give the training, and then the worker is now equipped to do the job. But maybe we need a chronic disease model of training. That is, training is something that we continually do to always maintain the health and well-being of the workforce.
I think that's a really interesting idea, and especially because we can't really see training as separate. And what we know from training, not just in home care, but throughout the healthcare industry, throughout every industry, is that it's not useful to give people tools and then put them in a situation where they can't use them. So, if you get training on say managing patient boundaries when they ask you to do something that you're not supposed to be doing or that you can't or don't want to do that's off the care plan. What about when your supervisor doesn't back you up? What about when when you have to leave the job anyway because it doesn't pay? Those training is only as effective as the environment in which that training can be implemented.
Yes, and another finding that I have that we found in some of our work was that if you ask people about their ability to manage something like patient boundaries and they've never really done it effectively, they might actually have outsized perceptions of their own abilities. And then if you give them a training and they never implement that training, they might still have outsized perceptions of their skills. But if you provide the training and they actually try to do it, they actually might have much lower estimate of their own capacity because they've actually tried and seen how difficult it is.
That's a really interesting finding, and I think very applicable to this work where we found that aides are doing work very deliberately and with a lot of expertise, but it is this homegrown expertise for the most part. Their own emotional intelligence and emotional skills that are driving this work. And some felt more confident in their ability to do that. Some felt less confident in their ability to do that. But one of the things that we heard, and this might not quite answer this question, but I think it's interesting in this context, is that workers had a lot of ideas about how to put things in place. When we asked them what they needed to do, they would say, you set boundaries, like you have to remember your client is your client. It's not a family member. You don't get too close to them. But then when we asked how they did that, they often couldn't answer that question. So in some ways, they know what they need to do or what they're being told they need to do, but in practice, it's much more challenging.
Yeah, it's very interesting. It's almost like an acting class where the requirement is a performative set of emotional relationships, then that it's also self-protecting in some way.
Right, exactly. And sort of the crux of this paper is that the study is that, we were looking specifically at the emotional labor that aides provide. So there are a couple of different levels of that. And emotional labor is a term that Arlie Hochschild coined to describe kind of these invisible job requirements. It's essentially basically like the customer service you do to make someone feel good. So, what you're describing is the surface acting, which is, when, you go to the coffee shop and the cashier smiles at you and asks how you're doing. But then there's also this deeper emotion work that we find that aides are doing where you try to change your actual feelings. There's a genuine relationship there. But if your client is yelling at you or having a bad day and you still have to feel that bond, that causes a lot of stress. And that's what we found was really challenging for workers when the feelings that they felt they were supposed to be having or trying to genuinely have were discordant with what was actually going on in the relationship.
Yeah, I think that's the heart of it, balancing those two things and maintaining a sense of well-being while you are caught between those different emotional demands.
Right, exactly.
Emily, I want to wrap up. I want to thank you for your time. This has been very, very interesting.
Oh, thank you so much. I'm happy to have this conversation, and thank you for inviting me.
Hi, Mom. How are you?
Good. How are you?
Good. Hey,
What's doing?
nothing much. I'm in my podcast recording studio.
Oh, good.
Is
You're lucky I answered because usually if there's no name, I don't.
I wanted to talk to you about a study that I read about, which has to do with caregivers for people when it's like a home health worker in your own home.
Uh-huh.
So
Mhm.
the questions, and I'm wondering if you've thought about this at all. The questions have to do with the emotional well-being of the workers and how they deal with the relationships that they have with the people that they care for. I'm wondering if you've thought about that at all.
Not really. Not really. Some people see it just as a job. Some people see it as a relationship with the person they're working with. So, and I've really never given that much thought.
Well, let's use an example that we're both familiar with. So the woman who helped Aunt Margie take care of Uncle Alan,
She's incredible.
yes. So they were there. One sister was there during the week, and one was there over the weekend. I guess when they were still back in Fort Lee, you had some interaction with the worker she had locally. So he, as you recall, I mean, he could be very pleasant, but he could also be very difficult. And it was the woman's, the worker's responsibility and her job to take care of him and also interact with Aunt Margie. And all of those women stayed on the job for a very long time. How do you think these women manage that emotional support that they're able to give Uncle Alan and also Aunt Margie?
Well, at the beginning, Uncle Alan was still able to have some interaction with them. He really couldn't. He wasn't functioning at the level he had been at when all of the dementia was starting. And he was conversational, and he was engaged in what was going on around him. And as that started to fall off, they became more like mommies. They would still deal with him on an adult level, but they couldn't talk to him the same way because he wasn't processing things the same way he had been. But they had already, Diana, primarily was the one who was with him during the day.
If you have an agency and they send out a worker to somebody's home, they're clearly responsible for, is this worker trained? Do they know what they're doing in the home?
Right, the whole background
do they do
check.
all that? And just have they had the training to do the work? But there's another level to it, which is, are they emotionally equipped to do the work? And do they have the ability to navigate these complicated relationships and emotions?
That's an excellent question and a very, very hard one to answer, and certainly can lead to a lot of heartache for the worker and for the person who needs the care. And I think it's on a highly individual base because you can hire somebody for an agency to send out. You can have somebody come into your home from recommendations. And people are people. They can have a very good relationship with someone, even while they're doing the most intimate chores with them.
Or they can just hate what they're doing, but they're doing it because of the money.
One of the reasons why people stay in those jobs is not just the money, it's the relationship that they have with the people they're caring for.
Right. I was just going to get to that.
But because the work is very intimate and demands that level of emotional and personal connection. But not everybody is equally equipped to do that.
Right.
So if an agency sends somebody out to your home to take care of daddy, for example, and their heart's not in it, then they're not going to do a good job. And it's not just about
Well, they might. They'll do. Look, we had somebody when my mother was dying, and it was very difficult for me to be there on a regular basis to check on what she was doing. But she reported to me every day, and Grandma was able to talk to me. She wasn't happy about the situation, that she had to have somebody in the house to take care of her and to deal with everything, because Grandma just, was just too ill to even get out of bed sometimes. And I was having a very hard time with it. Whenever I could get there, I would, certainly on the weekends. But during the week, I was working, I was taking care of you guys. Grandpa was traveling. Daddy was traveling. And the best I could do was hold on through the day until I was able to get to a phone and talk to her or talk to Remy. That was the woman's name who took care of her. And then reassure myself that she was being taken care of properly, kindly. That was the best I could hope for.
So do you think that woman had a relationship with your mother?
Yes. We had been able to hire her. She was a registered nurse at Columbia Presbyterian. And when we knew that she was going to die, we took her home because the hospital wasn't going to keep her. And we hired Remy, who had been her nurse in the hospital, to come and work for us privately. So we knew that they had a relationship. And I knew that she was being taken care of, certainly by a professional and somebody who had an aura of kindness. And that was really what I needed. I was afraid to bring anybody in that I didn't know or hadn't been recommended. But it's still, it's a very hard choice to make. It's a very, very difficult thing to do.
Hey, Mom, I need to get going. Thank you so much. Have a good day.
All right. You too, sweetheart. Thank you. Love you.
Okay, love you too. Bye-bye.
Okay. Bye-bye.
Thanks for listening. To learn more about the Gerontologist and to read its latest articles, visit the website at www.geron.org. The Gerontological Society of America was founded in 1945 to promote the scientific study of aging, to encourage exchanges among researchers and practitioners from the various disciplines related to gerontology, and to foster the use of gerontological research in forming public policy.